Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos, and if you're new to us, welcome. We're super excited to have you here because we're really passionate about having curious conversations with leaders that are painstakingly reshaping the future of healthcare. And we're really passionate about a few different areas. We're passionate about healthcare innovation, access, leadership, and the adoption of those innovations. And if it's your first time tuning in, let me just sort of take a quick step back to give you a little bit more on what we're trying to get done here. So, the ethos of the show is to bring real stories of innovation to life, not just the stuff that you're reading in headlines, but like people that are in the trenches getting stuff done, sharing the wins, and also sharing some of those learnings. We've got an amazing action packed here. If you haven't checked out any of our historical interviews, however you're consuming this, if you're watching this, if you're listening to this, please hit the subscribe button now so that any of the new interviews come directly to you. So look, I've been doing the show for a little while now, and there's a pattern that continues to emerge. And it's that the clinical side of healthcare gets a lot of attention. And there are certain parts of healthcare that everybody knows are broken, but they just don't get talked about enough. And money is one of them. And I'm not talking about like policy or, reimbursement models. I'm talking about what does it actually feel like for a patient to pay for care? And that part to me has been left alone. So today's guest has spent more than 30 years inside of the ecosystem of healthcare and fundamentally is focusing in on that exact problem. So Brian Marsella is the president of HPS PayMedix and Tempo Pay. So what the platform does is it's generally different. It guarantees payment to providers upfront. So it takes every bill that a patient owes and turns it into one clean monthly statement. Brian's going to go into a little bit more in this, but it gives every single patient a path to pay because no one kind of gets turned away because their financial situation doesn't fit the model. So like, just think about that. Like, no one gets turned away. And here's the number that really got me in kind of preparing for this conversation is that 1 in 4 people on the PayMedix platform would fail a standard credit check. So they would be denied financing anywhere else, but they still, need care. So Brian's held, I mean, his CV is ridiculous, but he's held senior leadership roles at Cigna and Aetna. And honestly, he's been inside those rooms where, risk gets priced and decisions get made at scale. And he knows exactly where the patient gets lost in the middle of it. So in addition, actually, he also serves as a board chair for the last, what is it, Brian, 15 or 16 years. It's been quite some time for Erie Family Health Center. So this is a federally qualified health center in Chicago. And honestly, where the communities that are walking through that door, they don't have the luxury of putting off care in many instances. And honestly, a confusing bill is the difference between someone that's coming back and someone that actually disappears, from that situation and system for entirely. So, Brian, it's great to see you. Welcome to the show.
Thank you, Michael. Appreciate being here.
Yeah. So, listen, I want to start off way back, go all the way back. I think it was like 1992. You're young, you just started at Cigna. Uh, what did you actually think you were walking into, and what did reality look like?
Yeah, boy, I'll tell you what, I took the job mainly because it was, a couple hours from my house. There was a 6-month training program, and I felt like it was a good way to get engaged in healthcare and to start a career. And I just thought I was going to be helping people price how much it costs to have healthcare, right? I started my career
Yeah.
as a financial underwriter, right? And it was one of the it was a great job. Quite frankly, I don't think I've been as good at anything as I was at the beginning of my career at pricing things. But it was interesting. We would sit down with employers and just tell them they had to continue to increase their deductibles and their out of pockets to bring
Hmm.
the cost down. And we believed back then that everybody was going to overutilize care if we didn't make them financially responsible. And we also didn't have all these clinical programs to help keep the providers from,
Right.
basically, ordering on, tests and everything. And this was back 34 years ago. The system is like, you know, 50-fold more, convoluted now than it ever was back then.
Yeah.
Back then you would say a high deductible plan back then was $1,000 deductible and a $3,000 out of pocket. So
Yeah.
very different. Like that's considered a rich plan today in today's world.
Yeah.
But I just it was a great start to my career. I actually went and got my MBA ostensibly to get out of healthcare. And when I was getting my MBA, I realized that healthcare was 20% of GDP. Why would I get out of
Yeah.
it?
That's right. That's
And
right.
so here I am, another 25 years later, and still involved. And I've been involved in every aspect. I've been on the consulting side, the national carrier side. I own I'm running a small business now, so purchasing our benefits, and then also as my board chair position. And I often will go back to the Kellogg Healthcare School and tell them that nobody would build the system the way it's been built if they knew what was happening today.
Yeah.
But it's going to be very hard to unravel the system with, the vast majority of the healthcare companies and the pharmaceutical companies being such a huge component of GDP and of the Dow Jones and all that we got to find a way to actually solve it. And one of the ways is to help people become better consumers. And
Mm.
we thought we were going to drive consumer driven health plans 25 years ago. We really haven't. We've gotten to the point where, as you said, a lot of people can't afford care. And so what's happening is they're just avoiding getting care. Kaiser Foundation says 4 in 10 people are not getting care because they can't afford it. So
Crazy.
that's,
Such a big number, man.
and you mentioned at the beginning of the clinical program, we focus on the clinical. Well, you can never trigger a clinical program if you don't actually go get care in the first place. And
Yeah.
so, think about even just getting a preventive care. That's free for most Americans, and most people still aren't getting it done because they're afraid there's going to be all sorts of costs that'll come out of that. They'll have to be on drugs, or they'll need other procedures, or they'll need testing, or maybe they actually get charged for the free care because somebody asked about hypertension
Yeah.
and they, flagged and coded the wrong way.
Well,
So it's
because
amazing
you've been
unintended consequences of the things we do, have
exactly,
impact on people's behavior.
exactly. So seeing that, I'm just sort of curious, like what drew you to this fintech company? That was it back in 22 or something like that. I mean, was it that problem in and of itself that you kind of looked into and you're like, wow, like this is actually super intriguing. And as you start kind of running the math and looking at numbers, I'm just sort of curious, what was it that really kind of brought you to that decision? 'Cause obviously, I think, look, you spent over a decade at Aetna. You left for Mercer as a consultant. Then you went back to Cigna, market president. I mean, most people would call that a career, but like you shifted from that to go into this. What's the thinking behind that?
Yeah, when I left Cigna, I started doing consulting for a number of what people might call it for as point solutions. They're solving a specific issue in the industry.
Yeah.
Fertility, mental health, centers of excellence, diabetes reversal. I was talking to all those folks, digital mental health. And what I was really intrigued by was, unlike the big carriers, they could spin on a dime. You could give them suggestions on their value proposition or on how to show their ROI differently or how to price things differently, and they would make changes and move things forward. So that got me intrigued by getting out of the large, stable company world and saying, let me try something unique and different. And if an individual I had known from back to the beginning of my career, we both started in underwriting together, had come in as the CEO of HBS PayMedix and really started throwing some statistics at me. The 4 out of 10 people are delaying care and 25% of prescriptions aren't picked up. And that,
Mm.
50% of Americans can't afford a $500 bill. And that, the average out of pocket, at the time, I think was like $800 that people were paying. So those lines didn't cross, right?
Yeah.
I started thinking about what happened with COVID. With COVID, when people physically couldn't get in to see their doctor, or they couldn't get into a hospital, or they were afraid to go see that doctor, right?
Yeah.
So
Yeah.
many people put off care. I mean, people that had no problem getting care before put off care. And at the time I was still at Cigna, we were talking about the third wave of COVID, which was really the people that were showing up with stage 2 cancer instead of stage 1. They were showing up with
Mm.
diabetes instead of pre-diabetes. They were showing up with, COPD that had, or asthma that had gotten worse. Um, and it was all because they couldn't get care. Well, what this individual explained to me was, for 50% of Americans, just not having access to cash is just like a door you can't get into or you're afraid to walk through.
Yeah.
And those people are also having the same sort of situations happen where they enter the system in the wrong setting. They'll enter it at, emergency room rather than, the primary care, or they'll just enter it, by the time they enter it, they're just sicker and you have a
Yeah.
lot more work you have to do. If you think about not only the cost of stage 2 cancer versus stage 1 or stage 0, but it's also the mortality rates of those.
Mm.
It's dramatically different. So be able to get people up front. And I inherently knew that from my days of trying to drive people into clinical programs and get
Mm.
people into programs. But again, if you don't find that they have this issue, it's hard to ever, deck up resources to help them get better. And then I started thinking about my nonprofit. And my nonprofit has the highest quality statistics in all of Illinois and is the top 10% of the country. And in large part, that I believe is because most of our folks are on Medicaid. And so we may have to work really hard to make sure they come in and get care. But
Mm.
once they're in, we deal with them in a culturally competent manner. They don't have these bills they have to pay. And we have to earn their trust to keep them in the system, but we do some amazing work. And I started thinking that the company I'm in now, if we can help solve some of the financial issues with people, that we can get them in the front door and we can actually take care of them the way we would in my nonprofit. And so
Yeah.
that's where it really intrigued me. It feels like a small sliver of the system. Um, and there's that great quote: if you optimize all the subcomponents of a system, you're going to suboptimize the overall system, right? Well, we are not trying to optimize that. We're trying to just make it easier for people to get in, to get
Yeah.
care, to then be able to work through all of the other, great solutions that their employer has put forth for them, or that their
Yeah.
provider has included, and make sure they're getting care in the right setting. And we've seen good results. We've seen more care in the physician's office and the outpatient than in the hospital. We've seen lower trend, and we actually see across all credit scores that people are accessing the system similarly. Not only the number of
Mm.
times they enter the system, but their dollar amount. We wear that with a badge of honor because I think you normally will see, particularly lower income folks or lower um, credit score individuals accessing the system differently. The stat I put earlier: 40% of all Americans are delaying care.
Yeah.
Of Americans making less than $90,000 a year,
Hmm.
67% of them are avoiding or delaying care. So you see a rapid increase when
67% are delaying
we're
care.
avoiding care. Yeah, yeah. And then you start
We,
seeing people that are, 5% of people are taking medical withdrawals from their 401k to pay for care. That's meant to be that's meant to be there for your later in life and
yeah.
your ability to retire. And a lot of people are having to take money out of that just to pay for their medical care. So if I could cite a million stats. They all fundamentally get to the point that Americans can't afford $1,000 bill, period. They're then going to delay it and put it off. And then the average right now that people are spending is 1,100 per person. So a family of four, 60% of those folks can't afford $1,000, and yet they're on average they're paying $4,400 in medical care. It's just logic and math that don't add up to having people access care in the right setting at the right time and feeling confident that they aren't going to go into worse medical debt that causes
Right.
problems back end, when that happens.
In a sense, do you feel like your board work at Erie Family Health Center has sort of humanized the problem for you to sort of see it? I mean, I guess maybe walk me through like, are there any specific situations, like a real story that you can share, um, that that kind of really made this crystallizes for you in terms of what you're doing on the day to day, but obviously with your board work, because I feel like those they cross paths for a reason. I just don't
Yeah,
think that it just sort of happened by coincidence.
yeah. No, you're absolutely right. So one of the interesting things about a federally qualified health center board is that 51% of the board members need to be patients. Okay. So we have 22 folks on our board. So I think right now 13 of them are patients and nine are, non-patient business type people, right?
Right, right.
And then even in that world, only a certain can generate their income from the healthcare industry. So it's very, very highly reviewed, in large part to make sure that the patients are the ones that are really helping to try and determine how the health center is going to operate.
Yeah.
And there's been many times when, when we look at the actual dollars of running a program of whether it's some of our community-based programs where we're doing life, healthy cooking classes, or, some of our clinical oversight of, people going into the home to look at the home and making sure that, people have access to things, or all the work that we do outside of it. It costs us money times to do that,
Yeah, that's
right?
right.
But the patients will walk us through how much that helped them with their overall care. And they'll say,
Mm,
we can't look at this as a dollar and cents issue. And that's unfortunately how most businesses look at things. We're going to say, we have to look at this as what's the best overall health of the community. And then we're going to have to go find the resources potentially to make sure we can drive that. That could be fundraising dollars. It could be, different way to get people in for care. That the kind of thing. So it really started helping me understand that we have to look at the overall issue, and we need to really determine what's the best interest of the overall health. And so it's the same for an employer in my mind. You have to think about, for that employer, I don't begrudge them for having increased their deductible out of pockets, right? That's something that they have to think about doing to make sure that their fair share of what is people pay out of their paycheck is
mm,
reasonable. Um, but then they have to realize that when you're trying to build a one size fits all for your employer base, you're going to have a
yeah.
subset that are going to be really sub optimized. So you have to find things you can bring to them that will help them, if nothing else, extend the time horizon of when they can pay back those bills, right? And so those kind of things really help me understand that, again, sub optimizing a piece of the equation or optimizing, for a certain financial component can sub optimize the overall health. And employers need to look at things, their absenteeism, their presenteeism, their healthcare costs, their, other benefits, and are people using those the way they want them to be used, to really be able to think about, you're delivering the right overall component to people.
Now, I've just been, as you're mentioning this, I've just been thinking, man, you have so much experience on the payer side, 30 plus years inside of the system. And a part of me, I guess I'll say the inner cynic in me is like, well, you're inside of those systems that, in essence, birthed this opportunity for PayMedix to solve this issue. Does that does that feel like ironic to you, or do you think about it differently?
It feels a little bit ironic, but in all honesty, some of it's such a big issue at a macro level. Medicaid and Medicare don't pay their fair share to the providers, so they need to go get more of the money from the employers, right? Now, we could have a lot of debates on whether the providers are using that money properly,
Mhm.
and we can have a lot of debates on, when you see all the land grab that's happening
Yeah,
out there. In large
right.
part, consumers are demanding that.
That's right.
Everybody's doing it for a reason, right?
Hmm. Hmm.
But back in the day when we started consumer-driven health plans, we really believed that that was going to be the thing that allowed more employers to continue to offer care, or to continue to subsidize care at the right level. And
Yeah.
it worked for a little while. It really did. It brought trend down. It helped along the way. But then as costs have continued to go up, it's really gotten to a teeter, the seesaw has gone too far in the other direction, and the unintended consequences of that have stemmed. Um,
Mm.
there was even a recent study that showed, people on that had cancer that were on a consumer driven plan had worse outcomes than people that weren't on a consumer driven plan. Now,
Interesting.
I can't blame that on the consumer driven plan. We all believed we were going to get people to be able to behave more rationally.
Right.
The whole concept behind this was you do more research to buy a car than you do to go find your surgeon for a heart transplant, right? You do
Isn't that
more,
interesting? This
yeah.
is this is mind-boggling to me.
And we really believed at the time in the healthcare world, and I still some people still believe it, that if we make it, people have the skin in the game, that they're going to ultimately start doing more research and more care. Well, some of it is the tools haven't progressed as fast as they should. Some of it is, providers. They say it takes 19 years for a provider in a given subspecialty to,
Hmm.
for everyone in that subspecialty to be delivering care at what that subspecialty delivers to be the most appropriate way to deliver care. Right.
Right.
So,
Yeah.
carriers play a role in making sure that that they try to make sure that that doesn't happen. Right. Some of
Yeah.
it is they're giving information to these providers that they can't get because people are going to multiple providers. Right.
Hmm. Hmm.
Uh, so there's still value in what all of these groups do. It's just gotten to the point where, you know, increasing deductible and out of pocket is making the system worse at this point in time. The business group on health says that they believe uh, costs are going up 9%, and employers are going to buy down about 1.4% of that, by increasing deductibles out of pockets or putting in other initiatives
Yeah. Right.
that will move more of that onus to the patient. A lot, employers can't, asking them to take even 7.6% is a lot. They're not able to get
It's a big
7.6
hit.
increase in all of their good, costs, all of their programs at times, right? So you can't point to them and say they're the problem. You can't point to the carrier and say they're the problem. You can't point to the provider, but you have to point to everybody and say there's got to be some things that we can do differently. And I'm a big believer in driving people to high quality care, maybe even through, lower copays, lower deductibles, or even free. Um, but ultimately, skin in the game is valuable, but you got to actually then have some tools and resources for people to be able to afford that over time and give them a time horizon to pay that back, like you would have them have a time horizon to pay for their car or their house or things like that. It's crazy that we have to think sometimes that healthcare is a purchasing decision like a house or a car. But, someone I was on a panel recently that said to somebody, you should let your employees know that on average, you're buying them a Toyota every year. And I started thinking, what is this person saying? And if you think about it, the average now for, per employee is well over $25,000 is the
Yeah.
total cost per employee for healthcare, right? You can
Yeah.
buy
It's not cheap.
Toyota for $25,000, and you're buying them a new Toyota every year, right? Like, we need people to understand that. And we need employees in particular to understand that that's important. They need to start paying more attention, right? But unfortunately, we've shut them off. We've shut them off by thinking I can't even go get care. Or sometimes on the back end, I can't have any understanding of what I owe, who I owe it to, when I owe it.
Hmm. Hmm.
There's rework of bills. There's all this stuff that happens. And unfortunately, to some extent, we've programmed people to ignore things. When I
So you
started
mentioned,
getting my care I started getting my care at my nonprofit. I've been on the board for 19 years. I became the board chair 16 years ago. When I became the board chair, I said I should get my care here. So I started getting my care there. Quite frankly, it's the best care I've ever gotten. I used to get care at some of the most prestigious, facilities.
yeah.
Um, I wasn't paying my bill until I got a red final due notice.
Yeah.
It might be like 180 days later, you're finally getting a bill that says final due. And sometimes it was, $150 that I owe.
Yeah.
I could afford it, but I had been pre-programmed to say, I'm not paying Northwestern Healthcare until I get my red final due, because I'm not sure if it's been paid, if everything's been
Right.
paid
Right.
for
Right. Right.
already. And do I owe? And then I would go and I would look when I got that red final due. I'd go look and say, do I owe the money? Right. Well, the reality is, the CFO at the nonprofit said, is there something we can do better in billing? I'm like, no, it's great. You guys do a great job. I said, well, this is kind of embarrassing for me to ask you, but why aren't you paying us in 30 days like we'd like you to? And I said, oh my goodness, I've been pre-programmed to not pay attention to any bill until I got red final due.
Yeah,
And so I didn't realize how much I was harming them. In essence, they were giving me a loan for 180 days for that $150.
that's right.
Because the nonprofit didn't have the money to do that. They're
And
nonprofit.
they got to float it, right? So it's like you magnify that by however many thousand patients are on the panel, right? So it's like that adds up.
And if Northwestern, I owed them 3,000, they were giving me 6 months to pay for it too. That's bad for them, right? They should be, they shouldn't be floating that money to people. They should be putting that into providing the best doctors and the best, call centers and all that sort of thing, right? And so, here's me in the industry, back then I'd been in for 24 years or whatever, 20, 30, almost 30, is not understanding the unintended consequences of my actions, right?
Yeah.
And that's what happens with a lot of things in this industry. It's people don't understand the unintended consequences of whatever you do is going to come back ultimately in the back end. It's going to hurt your provider. It's going to hurt your employer. It's going to hurt you as an employee. And, we got to find a way to help people make better decisions overall, and see the picture, the whole picture of the system. I don't have an elixir for that, but what we try to do in our small way here is give people a time horizon to pay their money back that they owe, so they feel more confident in getting the care at the right time in the right setting.
So wait a second. So walk me through this. Walk me through like this super EOB. Like I'm a patient who just saw the doctor, for like the first time. Like what used to happen is that what you described about, getting care and then getting that final bill, is that what used to happen? Like versus what happens now that, PayMedix, Temple Pay, like that now that you've sort of infused yourself into that
Yeah.
scenario.
Yeah. So we've got two distinctly different products, but the main product, which we've been doing for 20 years, is HPS PayMedix. We're actually a network of providers that all of them have agreed to not ask the patient for any money up front, right? And right now, nowadays, 43% of hospitals are asking for a form of payment before they'll give an elective surgery, anything elective procedure, right?
I literally was talking to a buddy of mine last week who was scheduled to go in for a procedure at a surgery center. And literally he was like, they had to move the surgery because they wanted him to pay like I think it was like 10 grand or it was not a small number. And
Yeah,
he's like, I wish they would have told me that beforehand.
right.
It's like because and he had the money to pay it, but he delayed it anyway. But that's besides the point. But he's like, I just wasn't ready to pay that. Like right there. He's like, I was getting ready to go in. He's like, they couldn't have told me that maybe like a day or two ago for me to like mentally process this. It's
No, it's so
wild.
true. Well, and that's the reality. The standard system is you have no idea what you're going to pay because you don't really know where you are in your deductible out of pocket or what the actual procedure is going to cost. They ask you to put it, many of them will ask you to put money down up front,
Yeah.
or at least a form of payment. So that's going to also, exacerbate my desire to go in. Then I'm going to go in and have the procedure done. I'm going to get a bill. I'm typically going to get a bill from the provider before anything's been done by the carrier.
Yeah.
So it might say, you owe $2,500 for this. I'm going to ignore that. And I should ignore that because it doesn't, the carrier hasn't determined what my deductible was, what my coinsurance was, were some of the pieces on the bill actually not legit. And so then they're going to process a bill. Then they're going to send me an explanation of benefits. Or most of the time now it's going to be you have to go online and look for it
Yeah.
online. I'm going to look at that and I'm going to be able to say, okay, I was billed. This just happened. My daughter had an appendectomy. We were billed $52,000 for the bill. There was a $20,000 reduction for cost. Most of the rest of it went out of. I think I owed $1,800 for my for deductible and out of pocket. Right.
Yeah.
So now I will wait till I get a bill from the provider that says there's $1,800 owed.
Yeah.
And then I will determine how long it is before I have to pay that bill because I would like to not pay it until I have to, right? And
Yeah.
that's how a standard system works. Okay.
Yeah.
In our world, it's very different. You'd never ask for money up front by the provider. You shouldn't be, right? The provider sends it into us. We reprice it to whatever discounts look like. We send it to the third party administrator. They adjudicate the bill, and then they send it back to us.
Mhm.
We then pay the provider both what the employer owed the provider and what the employee owed.
Right.
And so the provider gets that and checks it off and will stop sending you a bill every 2 weeks, while you haven't paid it. Maybe you've been waiting, been waiting to see what happened in the old world. They're paid in full, so they stop billing you.
Yeah.
We take that, we aggregate it with any other claims that you had that month, and we'll send you out a statement that is both a bill and an explanation of benefits. And it will say, Michael, for you and your family, there were 6 claims this month.
Mhm.
After all was said and done, you owed, of that $10,000 in claims, you owed $2,200.
Mhm.
How would you like to pay that? Would you like to pay that in full right now? Would you like to pay that with with a credit card, with your bank account, with an HSA account, with an FSA account? Or would you like to take out an interest-free, fee-free loan? And you, Michael, you have good credit, so you may decide, I don't, I can pay it off right now, or you may decide, yeah, I'll take that. No, if I'm going to buy a refrigerator, I might want to, they're going to give me 0 interest, and I can
Yeah.
pay it over time. I'm going to take that.
Mhm.
So you have the option to decide what you want to do, and you pay us once instead of paying those 6 different providers.
That's right.
So you also save some money and time and energy, matching up the bills and everything like that. If you take a
Yeah.
loan out, again, it doesn't matter, Michael. You may have somebody else at your company that is making low dollars, has a very low credit score. That person with us still has qualified to have credit up to whatever their out-of-pocket limit is. So we look at an entire group of, entire population of employees. So you've got that person has credit also, and they'll do terms with us. Right now, our average payment plan,
Yeah.
people owe us $3,900, and it's taking them
Uh-huh.
20 months to pass back.
Mm.
So when you go back to the stuff I talked about
That's
earlier,
fascinating. Yeah.
that most people don't have $1,000, right? So, it's no wonder that, a lot of folks are going to need a lot of time to pay that back. And what we'll do is, new claims come in. We can't automatically add them to your payment plan. We still have to have a
Mhm.
conversation with you to add them to plan, but we can add them
Mhm.
to that plan. And
Right.
for us, as long as people are paying us a reasonable amount of money, and we might ask, Michael, if you call up and say, look, I'd like to take this $1,000, and what can you do to give me credit for that? We might look at you. We know a lot about you, and we're going to say, hey, how about if you paid $250 over the next 4 payments? And you
Mhm.
might say that's totally fine. We might
Mhm.
look at that same, somebody else that has the same $1,000 that's making $40,000 a year, and we might say, how about if you pay us $50 for the next 20 payments,
Mm.
right? So we'll start off with a
So
payment.
this like there's like a give and take there. Because
Yeah,
because when I read the stat that there was like, 1 in 4 of your members would fail a standard credit check, I'm like, wait a second. You serve them anyway, which is great, right? But every other financial product, at least to my knowledge in America, they would turn those people away.
yeah,
And
right.
and yet, you've kind of gone against conventional logic and you've made it work. But it sounds like what you're doing is it's like you have like a relationship with the patient and you have an understanding with them. And as a result of level setting, it just it doesn't become transactional. It's like, all right, man, like I hear what's going on, do this. So it's sort of like a live negotiation. Is
It
that
is.
meant to be like that?
Yeah, it really is. I mean, because again, what we are here for is to make sure people get care. That's the bottom line, and to help simplify them, right?
Mm,
The providers actually pay us something to do this because
of
they're no
course.
longer having to bill, they're no longer having to collect, and they no longer have any bad debt. We take on all the bad debt. And then the employers may at times pay us something, depending on their plan design and their and the industry that they're in. But at the end of the day, we never ask the patient for any interest or any on their dollars, because what we're here to is to make sure that they get care. Ultimately, for the employer, it's going to be a good thing. right? Our
Yeah.
trend is significantly lower than the market average every year. And the utilization of the hospitals is significantly lower in our market every year when we do our studies. And so there's very few things in life, in my mind, that the provider gets a positive outcome, the employer gets a positive outcome, and the employee gets a positive outcome. And we do it
Mm.
by looking at a group-based product. There are some great solutions out there that you can get at the provider. If you owe $5,000, they'll actually have people at your bedside asking you if you want to get a medical credit card, right? Which could be
Yeah.
zero interest, but two things. One is you'll only qualify for what you qualify for. So you might
That's
only
right.
qualify for 2,000 at 5,000 or 1,000 of it. The other is if you miss a payment,
I mean, they
the
kill you on the interest.
23% interest back to the beginning, of
Yeah.
the Consumer Financial Protection Board was really looking at that a few years ago and was trying to find ways to make sure that stuff didn't happen. Ours, when you look at a group basis, we can handle that. We have another product that's really more of a credit card solution. And basically an employer can say, I'd like to, or a health plan, we sell
Mm.
to different folks. They can say, I'd like to extend $2,500 or $1,500 to all of my employees, no matter
Mm.
what their credit score is. And I'd like that to cover medical, pharmacy, dental, vision, maybe even vet care, right? So I'm going to
Yeah.
extend everyone a level of credit that maybe, again, your high paid people probably didn't need that, but your low paid people did, and you're trying to offer something across the board. So it's really going to be valuable to your lower paid folks. And that doesn't have, that can go nationwide, and that can be very simply set up. And the employer actually pays us to do that. They pay us a
Right.
per month, to cover our loan and to cover our bad debt and to cover the administrative costs. But they can then offer this very, good benefit across the board, to everybody in their population. And it builds health equity into their
Yeah.
plan, because the two people I was talking about earlier, when I said they might have different needs on the loan,
Yeah.
they have the same plan design, right? And so $1,000 means something very different to somebody making 40,000 than somebody making 400,000. Yet,
That's right.
typically you have the same plan design across the board. Well, our plan becomes so much more valuable to that person making 40,000 that had that same $1,000 bill. So we're bringing health equity into the equation. Again, our mission really is to simplify healthcare through, easier statements, as well as providing financing to get people to get care.
And listen, you're creating more access, right? So, I mean, I'm all about that. I mean, who's resistant to this? Because, I mean, it sounds elegant, right? I mean, the data is strong. There's a few things that I read that was like, I don't know, I think you guys have just released data that your employer groups are growing healthcare costs at 4.5% compared to like the national benchmark, which I think was like almost 9%.
Right.
So I'm
Right.
just wondering who's who's pushing back? Like
You
why
know,
are they pushing back?
Yeah, I mean, one of the issues we have today is we're really, here in Wisconsin mainly. We've got a few other, locations, but a lot of employers want a consistent program across the board, and they're not saying I'm gonna optimize my regional solution, right? So that could be some of it. Some just don't know about it. As much as we're out in front of brokers, consultants, we're trying to put things out there. A lot of them don't know about it, right? Um, and some think maybe it's too good to be true at times, right?
Mhm.
Underwriter in me has always said, increased deductibles out of pockets drives lower utilization, which allows a lower cost, right? A lot of people have trouble flipping that, actually some utilization is really important and is good utilization, right?
Mm.
And, the way we do it, where people will have to pay it back, they're just giving them a time horizon to do that, really
Right.
should, it really should only help that good utilization. It shouldn't promulgate, utilization that's frivolous, right?
Mhm.
So there's still a lot that we need to get the message out there. And then our other program is, again, it's nationwide. We're pretty new. We just bought that company about a year and a half ago.
Okay.
So we're out there getting the message out. And again, it's really, do people understand this issue that is the unintended consequence of your plan design choice that's come into play, and do they even know that there's a solution out there that can impact it? And then then you have to, and how can that fit into the myriad of solutions they put on the table? Some
Yeah.
are just reluctant to add anything else, you know. at this conference I was at last week, one of the biggest things they were talking about was we've over rotated to all of these solutions that you're implementing because the system
Yeah.
isn't working properly today
Right.
with
Right.
anybody using it. And that's what the reality is. You only add value when people are using them.
Well, what
I
do
think
you?
about diabetes. There are so many companies that are doing amazing work in diabetes, right? And we have
Right.
all these GLP-1s that are also helping with diabetes. You would think diabetes should be gone when you look at everybody's results. But
Hmm.
diabetes continues to grow because you just don't have enough people accessing those great programs and those great initiatives. Um,
Yeah.
or they're never being diagnosed up front the way they should, or they're diagnosed too late because they never went and got their care because they were afraid to go see that doctor because of the financial implications that could come into play.
What do you think most financial executives fundamentally misunderstand about like, the patient financial experience?
Um, I think there are some that don't feel that anything they do is going to change the way people consume care, and that may not be wrong. We have to find a way. I mean, part of this is people have to start engaging, right? I look at myself. I've lost 94 pounds since the beginning of last year without using any medication. I I feel better. I'm gonna have all my numbers are now in line, right? I had to make a conscious effort to do that. I had to think more like somebody that was thinking about my care versus somebody that just thought, well, I'll wait till the system covers me when I have something that happens later on, right?
Yeah.
And
Right.
I don't have to always get care, at the Cadillac of locations. You can go to an urgent care facility and get as good a care, or go see your primary care when you need to. Like, you have to change the mindset of members, and they have to be held accountable. Um, but but you can't always just do that through benefit plan design, which is the easiest thing to do because it can be consistent across the board. It can be, you can help try and think you make people make right decisions. So, you really have to think about it from a holistic perspective.
Mhm.
What can I do to, help as many people access the care at the right cost and the right setting? And that may have to be different solutions in different areas. I
Yeah.
feel bad for employers that, you look at a Walmart, it's got 500,000 people that they're trying to set a plan design for in, 50 different states and, well, even globally, right?
Right.
They're trying to make decisions, that optimizes. And I've never worked with Walmart, so I'm not using them as an example of anybody
Right.
I
Right. Right. Right.
do anything right or wrong. But if you think about the decisions that they have to make, they're difficult. And how do you offset what people pay out of their paycheck versus what they pay at point of care? How do you offset, how do you try and find ways to get people to do things? Well, one thing is just, find ways to help them be accountable for the dollars, but not accountable immediately to have to pay those dollars. It's a small component that I think has a big impact on how people consume care.
So then if let's just say fast forward 10 years from now, if PayMedix, Tempo Pay, HPS, if they're working at the scale that you believe they can be working, what does healthcare look like in that future? Like paint the picture for me.
Yeah. I mean, quite frankly, we'd love it to be over all networks. We don't really have a desire to build new networks. We want to have our
Hmm.
financial solution that's baked into Wisconsin and a few other places included, with the providers and with the carriers. I think the carrier provider relationship would be better. I think the member provider relationship would be better. You'd have people getting care at the right setting, which ultimately will start to lower costs. I mean, there's so much more that needs to be done to lower costs. I mean, as you know, 2% of people are typically driving 60% of the overall care. Um, but, finding way to help make sure people are doing the right decisions. The more you can take friction out of the system without just simply making everything free, because that's some people's way to take friction out is we'll make everything free. When
Yeah.
you can take some of that friction out, you can do it in a way that helps all three stakeholders: the employer, the provider, and the member. You can start to rein in costs. You can start to have a more health plan that's more equitable, and hopefully we can start really making an impact on this trend because it's unsustainable. It's unsustainable the way it is to now. I mean, employers again, how do you know how, if you can only get 2% a cost increase from your consumers, your customers, and you're getting a 9, 10, 15, 30% from your healthcare, which is one piece of your
Mhm.
cost. You know, how do you how do you stay afloat? And the employer healthcare system. A lot of people are thinking about ICRAs. We're hearing more and more about people trying to get out of the healthcare system, but the problem with that is there's not a great individual plan to put people towards, and then you lose control of any of that to help think about presenteeism and absenteeism. So find a way to bring an equitable health plan to your customers. Find a way to partner more with providers. Some of it may be off, there may be some subsegment direct contracting with providers, and
Yeah.
we become a conduit to help with that. That's how we're going to change the system. I think we're a piece of the equation, but I think we're an important piece.
And before I let you go, just share with the audience what's the best way for people to follow you and the work that you and the team are doing. So kind of give us like a commercial before we wrap.
Yeah, we'd love people to connect with us. Our paymedix.com or hps.md are our websites. We follow me. We put out a lot of thought leadership pieces. We do about 6 to 10 a year that are really about the issue, and how people need to think about it. Yes, we'll talk about our products as part of it sometimes. Sometimes we don't even talk about our products. But
Mhm.
really try to follow us follow us on LinkedIn. We do a lot through that channel. Take a look at our websites and just understand the issue. Go to some conferences. We're at a lot of conferences, and we're trying to help people understand the impact of avoidance of care and
Yeah.
how that's causing problems. And you know one way to try and find to solve that is to find a way to include financing either directly through one of our products, and we have a number of competitors doing something similar, or try and help your network carriers to think about the way that they can build patient financing into their overall solution.
It's just been, I don't know, it's been really delightful to chat with you just because I think what makes your perspective super valuable is that you've been inside of the system long enough to know exactly where things kind of fray, and you've made this conscientious choice to fix it from a different angle. And very grateful that you came onto the show and just having a great conversation today. So for those of you that are listening to this, if you found it interesting, if you liked something, comment on it, engage with us, like it, share it with a friend. Um, we're a pretty interactive community. So this is a living, breathing ecosystem. Sometimes you got to give and share before you take. So, and if there is a topic that you would like for us to explore, or maybe a leader that you want to hear from, drop me a note, drop me a line. And remember, it's a platform about community, not just content. So thanks for listening. Keep building with purpose, and we will see you next time on the Advancing Healthcare Innovation Show.